Great. So thank you very much for joining us this evening. You're all very welcome to our second virtual question and answer session. My name's Ian Dodds. I'm the Director of Children's Services at Richmond Council. So the purpose of us coming together this evening is to provide you with the latest information that we have about the COVID-related measures that will be in place when children return to school later this week or next week. And to provide you with some more information on the vaccination rollout for children in our borough. So alongside me tonight is Dr. Patrick Gibson, who is one of our local GPs and also the Richmond lead on the NHS South West London Clinical Commissioning Group, and Azmat Nisa, who is one of our consultants in public health at Richmond Council. So each of them is going to give a short presentation and then we will open up to you and your questions. Before I do that though and let Azmat and then Patrick speak, there are some guidelines that I just need to run through. So first of all, the event is being recorded and we'll publish it afterwards on the council website for those who haven't been able to join us in person this evening. You'll all notice that you're all muted, except for us on the panel. So if you wish to speak later to ask a question or to make a comment, then you need to raise your hand in the meeting and someone will magically unmute you so that you can ask your question. And then when we've finished, or when you've finished asking a question, you'll be muted again. You should see the virtual hand at the bottom of your screen. You can also use the chat function, which is on the bottom of the screen as well, if you want to ask your question in there or make a comment rather than speaking in the meeting. If you do speak, feel free to have your picture on the screen. If you don't want to do that, though, that is fine. I meant to say turn your camera on. Those words escaped me during the meeting. But if you want to turn your camera on so we can see you in the meeting, that's fine. If you don't, that's equally fine. If you could keep your questions as brief as possible, that would be helpful. And if you could avoid repeating a question that somebody else has already asked, that would also be helpful, unless, of course, you think our response hasn't been clear or you've got a follow-up question. We also sent you at the beginning of the meeting some event etiquette. You should have received that with your email confirmation for this evening's meeting. And I'm sure I don't need to remind you of the need to be respectful towards everybody who is in the meeting this evening. And then lastly, in terms of the guidance for the meeting, we will send you out the information that we've shared at the meeting afterwards, including our presentations, and we'll put as much information on our website as we also can. So that's all in terms of an introduction. But before I move on, I just really wanted to acknowledge how challenging the last 18 months have been for our children and young people in the borough, and of course for you as their families as well. And also for our schools who've had to radically change the way that they have approached teaching and learning. And the new responsibilities they've needed to take on, for example, in terms of testing and tracing, and the management of suspected cases in their classrooms. And although most of our children, certainly those that I have spoken to, have been and have remained remarkably resilient during this period, a small but really worrying number of children are finding this situation really challenging, and they're continuing to face those additional challenges, particularly with their emotional health and well-being. And that's why it's really important that we return to as much structure and routine as we possibly can. And that's why it's important that we have that safe and well-planned return to school. So I hope this evening that we can give you the reassurance that you're looking for, that schools have done and will continue to do all they can to plan a really safe return to school for children in the next couple of weeks, and that they'll welcome children back and encourage them to get back into their learning as quickly as they can. And obviously supporting that is an effective plan to roll out the vaccination to children and young people, or eligible children and young people across the borough. So that's what we're going to update you on this evening, and to give you the opportunity to ask us any questions that you may have. So I'm going to hand over now to the first of our speakers, who is Azmat, who is our consultant in public health, and then we'll hand over to Patrick after that, who is our GP lead, and then we'll open up to questions and answers. So Azmat, did you want to proceed with your presentation?
Thank you, Ian. And I'd just like to share a few slides, if I may. So I'm just wondering if colleagues can see my slides.
Yeah, we can see those on the screen. Thank you.
Wonderful, thank you. So I'd like to go through some of the key things that have been happening in the area. So I'd like to cover in my presentation surveillance data and give you an update as to what's been happening with COVID-19 in Richmond. I'd also like to go through some changes in the guidance, the recent changes in guidance, and also go through the vaccination JCVI updates. And I know that one of our other speakers is also going to cover that topic too. So in terms of what's been happening with the case rate and the cases, this particular slide shows an epicurve, and what that really means is a curve that describes what's been happening in the case rates. So we know that in June, for example, the cases had gone down, were quite low, then they started to rise again and peaked in mid-July, where we see a peak in the curve. We can then see moving towards August, the number of cases going down, and then we saw a slight peak in mid-August, and now we see a downward trend in the number of cases. And if we look at more detail, the case numbers and rates, for example, the number of cases in the last 7 days in Richmond have actually, compared to the previous 7 days, have decreased. And Richmond's incident rate is higher than that when we compare to the London rate at 222 per 100,000. When we look at testing numbers and rates, we know that Richmond's test rates per 100,000 is higher than London, so more people are being tested. And we also know that the PCR test positivity rate, i.e. the number of people that are positive that have tested, has decreased and is lower than that when we compare the London average. So this slide may look quite complex, but if I may explain, it's quite simple. On the vertical axis, we've got age groups. They range from 0 to 4, going up to all ages, 80 plus. And on the horizontal axis, we have the date, which ranges from August, beginning of August to the latter part of August. The deeper the colour, so what you see in front of you, the deeper the colour visually, the higher the incident rate. So here we can see that the incident rate in the cohort 17 to 24 years age cohort is higher compared to some of the other age cohorts, such as the very young people 0 to 4 and also the 80 plus, or in fact 60 plus. The highest incident rate can be seen in the 16 to 17-year-old age group. So this really shows that young people within the 17 to 18 and 17 to 24 year age bracket have the highest incident rate. So moving on then to vaccinations, the overall picture with vaccinations is that for the, excuse me, for the first dose, we've got a really high coverage and a good coverage of 95%. And for the second dose, we're at 87% for the population, or the eligible population, of Richmond. So overall, that shows a really good vaccination coverage rate, which is one of the highest in London. So it's good news for us to see that. So moving on then to some of the key changes in government guidance. So we can expect from September that bubbles and social distancing are no longer a requirement. So, for bubbles and reduced mixing in groups in any education and childcare setting, no longer a requirement. However, if those settings choose to keep those measures in place, then that's absolutely fine, and it's a good precaution if they decide to do that. In relation to face coverings, another change that has come about is that we're no longer required to have face coverings in education and childcare settings. However, it's still recommended that for transport, particularly dedicated school or college transport, that face coverings are worn. Moving on then to cleaning and hygiene. Again, the guidance on appropriate cleaning and hygiene is that we continue and maintain cleaning regimes in settings like schools, early years settings, colleges and universities, and that's really important, particularly through the winter period, to help contain and control the virus. Good ventilation is key and very important, and that remains a key priority, and there is guidance that's available on the .gov website around ventilation. Moving on then to vaccination. So fully vaccinated adults and under 18s, regardless of their vaccination status, will not need to self-isolate anymore. In relation to contact tracing, schools and colleges and early year settings are not asked to undertake routine contact tracing. Contact tracing teams in the NHS, in the test and trace, will be limited to close contacts only. In relation to testing, students at secondary schools will be asked to take 2 on-site tests when they join school in September at the beginning. And then after that, after the 2 tests, they'll be expected and be asked to test twice weekly, but in the home setting. Staff across all education settings are asked to test twice weekly as well until September, and there'll be a review after the September date. 16 and 17-year-olds can now get the vaccine, and for 12 to 15-year-olds with underlying conditions or those who live in a household where there are members who are immunosuppressed, immunocompromised, they will also be offered that. So moving on then to the Joint Committee on Vaccination and Immunisation, and I'll abbreviate JCVI for that, just going forward. So there's a statement by JCVI which provides an update on COVID-19 vaccination, and the key things to note there are that there's an existing offer of 2 doses of the vaccine to 16 and 17-year-olds who are in the clinically vulnerable, extremely vulnerable risk groups. In addition, JCVI advises that all 16 to 17-year-olds should be offered a first dose of the Pfizer vaccine, and the Pfizer vaccine is the only authorised vaccine for young persons aged 12 to 17 years in the UK. Advice is to offer the vaccine to those 12 to 15 those who are 12 to 15 years at increased risk of infection, will need two doses of the vaccine. And a point I've missed out, and if I may elaborate on that, is so currently children with severe neurodisabilities, for example, Down syndromes, those with underlying conditions resulting in them being immunosuppressed, they're with severe learning difficulties or those who are on the disability register will also be offered the vaccine. Moving on then, the Joint Committee or the JCVI also specify that the Pfizer vaccine, in relation to the usage of the Pfizer vaccine for 12 to 15-year-olds, they'll be collating and accumulating data so that they can gather some more intel and information about the experience that this particular age cohort experiences, and they will collect the data and they will have that to inform decision making in the future. Pfizer vaccine is usually given in the upper arm. It's found to be safe. Most frequent adverse reactions include things like just a general sort of mild, self-limiting, short-lived sort of reaction, which typically lasts 1 or 2 days, and it includes things like soreness of the arm in the area that the vaccine was given, fever, and a mild headache as well. This slide really just outlines the fact that there are measures in place that will monitor and review COVID measures. It's also reassuring to say that measures are in place, so there isn't a need to worry that things won't be relaxed to that detail, and that if there are outbreaks in settings like schools, for example, they will be picked up, monitored and managed in the most effective way. My sort of last main slide looks at some of the key messages. Some of the key messages are around, for example, we know that in education, we know that education is a really key and integral part to a child's social and emotional development, and it's really important to get children back in education and back on track. It's also a legal requirement to send our children to school. And some of the other key messages to take home from today's session is that children are at very low risk of becoming seriously unwell from COVID-19, and that children will be asked to take 2 tests on the start of term on site, and then to test twice weekly at home after that. By September, all teaching professionals will have had the vaccine, and by October or mid-October, the teachers and teaching staff will have been double vaccinated or will have been offered the double vaccination for double dosage. So those are some of the sort of key messages to take home. Then moving on, finally, this slide just contains a lot of useful links to websites that provide further guidance in detail, should parents wish to look into anything that's more detailed. So say, for example, the Teaching blog or the Education Hub blog contains a lot of detail. We've got more details around the JCVI guidance and the statement. So all of these are available on the World Wide Web, and they are easily accessible. So that's all from me in terms of the presentation, and I'm just going to put my camera back on now. So over to anybody if there's any questions, or over to you, Ian.
Thanks very much, Asma. That's really helpful. We have had some questions in the chat which are being answered, and we'll come to questions at the end. But I'm just going to hand over to Patrick, who will give us an update on the vaccination programme. And I know in his update he will answer some of the questions that we've received in advance of this meeting. So over to you, Patrick.
Lovely. Thank you very much, and thank you for inviting me to talk today. So as Ian said, I'm Dr. Patrick Gibson. I'm a GP in Barnes. and I'm the vaccination clinical GP lead for our borough and GP borough lead for Richmond in South West London, CCG. So Ian mentioned before that all of the local practices and other NHS services have been really flogging themselves since December to make sure vaccination's been as accessible as possible for local people. And it has been a huge effort to manage on top of the rest of the workload as well. So this is a chance for me just to thank everybody who's been involved in that amazing effort to vaccinate our community and help to keep everybody safe. This goes way beyond our paid workforce, to be honest. We are exceptionally fortunate in Richmond to have the most extensive voluntary sector in the country, and hundreds of volunteers have given up their own time and offered additional resources, including tents actually for some of the sites, to support our efforts and help us to get back to something like normal. And we're incredibly grateful to each and every one of them, as without them, to be honest, it simply would not have been possible. I'm really pleased to say the public's response to the COVID vaccination programme has been fantastic in South West London. As Matt referenced there, Richmond has led the way amongst our 6 boroughs. By mid-July, on top of the figures that you've already seen, by mid-July, more than half of our total residents, as I gave you the figures for our eligible, but more than half of them had been vaccinated by mid-July, and nearly 90% of our over 60s. So it has been a fantastic response. And although COVID is still present locally, and rates are still currently quite high, it's clear the vaccination programme is helping to keep people out of hospital. So when we were running with those high levels before, we were seeing a lot more hospitalisation, a lot more death. So the success of the programme to date reflects that. Yeah, that's really great news. So as of mid-August, the data showed that 4 million infections have been prevented across England alone. 82,000 hospital admissions have been prevented. Last Thursday's public health report illustrated somewhere between 102 and 109,000 deaths had been prevented by vaccination so far. And already we're in the happy position that of our 18 to 24-year-old population, 75% have already had their first jabs. So, having said that, the significance of COVID infection in children and young people, it's less to do with the likelihood of hospitalisation and severe disease. Happily, deaths in children due to COVID, they've been extremely rare, and mortality has been consistently maximum 1 in 1,000, and that's quite heavily weighted to comorbidities. So reassuringly today, actually, a large trial suggests that with long COVID symptoms in young people, that's actually only running at about 2 to 14% of infected patients, as opposed to the 25% reported earlier in some of the Russian trials. So even that's good. But what is more relevant, of course, is the impact for children and young people on their social and emotional development. The capacity to travel, their learning, and this has been reflected in the disruption to their schooling, which you'll all have seen, restrictions to their socialising and the mental health impact of children and young people, and that's been significant. There are studies which show that up to 1 in 4 young women have had significant mental health upsets during COVID. So we should not be underestimating the impact of this, just because the hospitalisations and deaths are not in the same ballpark. Some young people particularly have been more negatively affected by others. For example, our population with special educational needs, where access to key support workers have been restricted, perhaps through those key workers testing positive or having to isolate, and that's put more pressure on families. Many of you will have been aware of all of that. So looking to their futures as well, we're also seeing examples where some educational settings and employers are stipulating that individuals have to be vaccinated before places are made available, and that's obviously going to potentially impact on life opportunities for our children and young people. So the reality is that while the virus will continue to evolve, it's unlikely to go away anytime soon, and we are likely to have to live with it. And vaccination is clearly a major part of that. Having said that, though, it's really important for me today to emphasise that vaccination is a voluntary activity, and people should not feel pressurized into having it. And what health professionals need to do, and what I hope to do today, is to offer the best quality information we've got at a given point in time to help people to make the best decision for them. We should not be haranguing people into getting vaccinated. Ian mentioned we've had a number of questions submitted in advance. I'm going to try not to repeat the answers to some of the questions that were submitted for our previous webinar. I think it's been referenced already that the recording of that is available. So some of you might want to have a look at that previous webinar to cover some, to see if some of the other questions are answered there. But I'm going to start with some of the key ones and repeat some of the key ones. So basically, who under 18 years old is eligible for a COVID vaccination? Basically, there's three categories. There's everybody under the age of 60, everybody over, sorry, the age of 16 is now eligible. They should have been contacted already and offered the vaccine. For some of these people, the contact information that we've had on record has been parents' mobiles, which is not infallible. So if you have an over 16-year-old who has not yet been offered the vaccination, please contact your practices because they are eligible. The second group is the group that I referred to, which is the children aged 12 to 15 with conditions that make them more at risk of the complications of COVID. So these are the severe neurodisabilities, Down syndrome, immunosuppression, and multiple or severe learning disabilities. The practice has been trying to identify those patients and contact them to offer vaccination to them. So they should have been offered vaccinations now. And then the JCVI, the Joint Committee for Vaccination, has also recommended that children and young people aged 12 to 17 who live with an immunocompromised person in their house should be offered the vaccine. And that's obviously to primarily protect the immunocompromised household contacts who are at serious risk of COVID. Immunosuppression is a difficult concept to grasp. It has a very specific meaning medically, as opposed to perhaps what is understood in the general population. So if you suspect that that does apply to a member of your family, please do contact your GP and they can clarify with you if that's a relevant factor for you. So, and then how do we actually access the vaccination? So as of the moment, where you go to school is not relevant. So currently within the vaccination programme, that's irrelevant. So you can go to school outside of the borough and that won't change things. It is possible though, as we drop down to the 12 to 15 year cohort, some vaccination may be delivered in school. It's not been decided yet, but that's possible. But for the moment, your schooling doesn't matter. It's really where you are resident, where your GP registration is. So everybody over 16 will have received or should have received a letter from their GP or the National Booking Centre inviting them to get vaccinated. So that's one. There are several possible avenues. Your local practice may be part of a PCN, a primary care network grouping of practices who may be offering vaccinations. So Acorn, Essex House and Hampton Wick Surgeries are all doing that at the moment. Harlequin's Rugby Club had been hosting vaccinations in recent months, but they switched off on Monday because the rugby season is about to start. Their contribution has been outstanding, and we're really, really grateful to them for everything they've done for the NHS and for local people. And they have been doing walk-in appointments, but we do still have walk-in appointments. So they're available at the Teddington Health and Social Care Centre, which is at the back of Teddington Memorial Hospital. And that's Monday to Saturday, 9 AM till 3 PM. And also at the mass vaccination sites, currently open at Queen Mary's and at Hawks Road in Kingston. A number of local pharmacies in Richmond are also preparing to offer COVID vaccination, and the local NHS and councils will share information about which pharmacies that is on their website. I have a list, so if people don't want information on that, I can give that in the question and answer session. And that information is often available through social media because we're realising that with the younger population, social media is a really important strategy in terms of getting information out to them. So if you're a Kingston resident who happens to be on this call, you'll be able to find out about local vaccination on your council's website. Important to say the aim is to make vaccination as easy as possible. And we've made sure that vaccinations are available at a time to suit each cohort as we've gone along. And we know that the appointments for the population that we're moving into now need to have extra flexibility. And we know that some young people have been motivated to make booked appointments, but then they get a better offer and they miss the appointment. That's fine. Their lives are more fluid and they're livelier, they're more fun than mine. And if they get a better offer, that's great. What we need to do, though, is make sure that we're offering as flexible access as possible so that they've got another early opportunity to be jabbed as soon as possible afterwards. So we're not going to get hung up on people not turning up for appointments. And we know, for example, that pop-up clinics at sports fixtures and walk-in clinics have worked really well for many. And some of our Richmond community are likely to have been at Reading Festival over the weekend. And I know that they had the opportunity to be vaccinated there. It does feel at times as if we lose all of our population to Reading at this time of year. So, yeah, so flexibility is the key message there. As mentioned earlier, that Pfizer is the product that is authorised for children aged 12 to 18 in the UK. Moderna has actually been approved by the regulatory authority, but the Joint Committee has yet to approve that for the vaccination programme. So it's likely Moderna will come available soon, but it's Pfizer at the moment. Most important thing that I think most parents want to know and what most individuals want to know is what side effects might they get. So any side effects are usually mild and shouldn't last longer than a week. Commonest ones by a country mile are sore arm, that usually lasts 2 or 3 days. Feeling tired is not uncommon, headache, feeling achy, feeling a bit nauseous is not uncommon. Temperature can happen, slight temperature, usually under 38 degrees. If it's over that, it's always worth thinking about other possible causes for infection. So a high temperature, you should not be putting that down to the vaccination. And occasionally people are getting lymph node reactions as well. There's been some interesting reports, important reports that have been submitted in the UK and other countries of an extremely rare occurrence with the Pfizer and the Moderna vaccines of some what's called myocarditis, so inflammation of the heart muscle, and pericarditis, which is inflammation of the membrane around the heart. So that's with Pfizer and Moderna. Rare, but important. This is a condition that you can often see in other viral infections. While it is a very rare side effect, there are some groups who are more likely to see it. So young men seems to be more likely to see it. And they're also more likely to see it after their second jab. Presents with pain, shortness, breath, palpitations. So if it happens, report it. But reports are rare. The reports where this has happened in young, healthy individuals, they're reassuring in that it's not life-threatening. It's transitory effect, short-lived, no lasting impact for the individual. But these reports, however, will continue to be closely evaluated by the Medicines and Healthcare Regulatory Authority and the Joint Committee. So that we're definitely keeping an eye on that. We were asked whether vaccination could trigger any inherited autoimmune conditions in one of the questions submitted in advance. There's no evidence that that can happen to date. So this can give us some reassurance on that. One of the nice things about living in the UK and having the States across the water is that often medical products are released earlier in the States, and that gives us a lot of data about safety. So I think many of you will probably know that the States have been vaccinating their over 12s for some time now. And the States have got a reporting structure called the Vaccine Adverse Effects Report, so VARES. And the good news from them is they have looked at 8.9 million adolescents so far. And then the reported incident rate there is 1 in 1,000 are reporting significant side effects there. 90% of those are minor significant side effects. Fainting is by far the most common one there. And the conclusion on the data that they've looked at as part of their vaccination program is that the incidence of side effects was consistent with what had actually been reported in those early trials way back in the summer and autumn of 2020, I think now, isn't it? With the exception of the myocarditis. So the heart one is new, but all of the other side effects had been reported in the trials, and nothing else has come to light since then, other than that heart one that I've already referenced. A question asked about why only one vaccine offered at the hubs when a number of 16-year-olds have had two. So currently the second vaccine is only being offered to 11 to 18-year-olds where they are in the clinically at-risk group. So for the moment, for the 16 to 17-year-olds who are not clinically at risk, then they're at the moment being only offered one vaccine, but we know that the Joint Committee alters their recommendations as time goes along, as data becomes apparent, so there may be a change in that. We do know from the vaccinations done so far that where a second dose is to be given, it is more effective when given at 8 weeks and not earlier. So we do know within the programme to date that there have been incidences where people have had them earlier. That's not desirable because the response is better at 8 weeks. Question about the long-term safety of the vaccines. Vaccines obviously have been around now for a decent length of time. As with all medical products, there is a strict regime of testing and accreditation that goes through, and nothing was rushed with COVID. So it went through exactly the same process that the flu vaccine will go through. So the safety, we are as assured about that as we are about any other vaccine that's been introduced to date. Things do become apparent with the passage of time, and that's fine. We live with that. That's a normal part of any medicine process. But this is no more experimental than any other product that you will have seen on the market. So the evaluation process went through the same process that I talked about. We were lucky that the development was aided by international cooperation on the DNA sequencing of the virus, and the availability of the new messenger RNA technology for manufacturers helped us to actually make it quicker than we would otherwise have been able to. So that has meant that the whole process of preparing a vaccine has been quicker, but there's been no shortcuts on the approval bit. So again, just to give as much reassurance as I possibly can, the same strict standards of safety, quality and effectiveness set out by the International Medicines and Healthcare Products Agency have been adhered to with this. And as I say, data is constantly becoming available to help evaluate it, and adaptations are being made to the programme as time goes along. And you've seen a clear illustration of that with the decision in the younger population not to use the AstraZeneca vaccine because it was safer to use the messenger RNA ones than it was to use the AZN product. So I hope that does give reassurance on that. Obviously, with prevalence being reasonably common in the community of active COVID infection at the moment, what's the best time to have it if you have been tested positive? If you have tested positive, then 28 days is the answer to that. If you have been asymptomatic and come up positive on a test, then 28 days from the time of the test. So that's the answer on that one. Parents may have a youngster who's got a particular condition, and they might want to know if that condition means that vaccination should be given extra thought. If you're in that situation, recommendation: talk to your GP, because your GP knows that history best. They've got the records there, and they're best placed to advise you. There are actually very few conditions which have an impact, which would actually mean that there is more risk from having the vaccine than not having the vaccine. So with virtually every condition, it's safer to have the vaccine than not to. But if you have any question and you want that reassurance, then please do ask your GP. Questions submitted about asthma. If a youngster's had a history of asthma and they're under 16 at the moment, should they go forward? From a risk perspective, COVID's now seen more as a vascular condition in terms of the complications than a respiratory one. And that's a bit different from the way it was seen at the start. So at the start, the doctors were all looking at those historical respiratory conditions and thinking that perhaps meant people should have a higher priority. But as time went on, we realised that was less the case. So asthma is not seen as a particularly high priority now and wouldn't affect prioritisation for vaccination. Similarly, a past history of a single episode of pneumonia would also not define somebody as being more at risk. So the only situation where that might be different would be if somebody had an underlying condition which affected their immunity. So if they were immunosuppressed, in that situation, of course, for the reasons I said earlier, those people would be prioritised. But again, if you have any questions in relation to that categorisation, your GP is the best placed person to advise you. Next question that came through was about the impact on periods, and some really interesting stuff about this in the press. There are reasons why theoretically you might expect vaccinations to have an impact on periods, because we know that there are immune changes that go on around the time of periods, which can be relevant in that. But the Medicine and Healthcare Products Authority has actually evaluated reports of suspected side effects and concluded at the moment that the evidence does not support a link between changes of period and the vaccination. Furthermore, and this has been a common thread through particularly social media, so we've been watching this really carefully, there is no evidence to suggest that the vaccinations affect fertility and the ability to have children in the future. So again, as things stand at the moment, we can give you reassurance on that score. And the final question before we go to Q&As, one really good question was, can children be vaccinated without parental consent? So this is one that's a really good question. So doctors don't like it if children request a treatment and the parents aren't in agreement. We're much happier if there's been a good discussion between parent and children and they are in agreement that they want to press on with whatever treatment it is, whether it's vaccination or anything else. And we will always encourage a discussion towards an agreed decision. But the legal framework in the UK does stipulate that if a young person has informed their parents of a treatment that they wish to receive, but the parents do not agree with that decision, it is possible for treatment still to go ahead if the child has been assessed as being a thing called Gillick competent. So Gillick competency is an assessment that was brought out it came out a long time ago in the context actually of contraception, I think. But it's the principles of Gillick competence can be applied to a number of other areas, and this would be one of them. And the ethics groups nationally have been looking at this and advising us about this. Competency is not defined by specific questions, but doctors are expected to take into account a number of different considerations. So the child's age, maturity and mental capacity, and the child's understanding, the young person's understanding of the issue and what that involves. And so looking at advantages, disadvantages, potential long-term impact, the person's understanding of the risks, implications and consequences, how well they understand any advice they've been given, understanding of alternative approaches, and also the ability of that person to explain back to you the rationale for their reasoning. So there is the system is set up so that potentially a young person can express a desire to have any treatment which their parent would not necessarily want for them, but they would need to go through that process, formal process. I'll close on that one. Right, so I'm going to finish there, Ian, and go back to you and maybe look to see what other questions we've got.
Great, thank you very much, Patrick. So the chat has been hot with questions, and as Matt and I have done our best at answering those that were in our sphere of understanding, but there are several for you, which you obviously haven't been able to answer because you've been speaking. So if I run through some of them now, and some of them are follow-ups to what you have said. So the first question in there is around what is being done to understand and to reduce the risks of long COVID on children and young people.
Sorry, of long COVID. Okay, yeah, thank you. I thought you said non-COVID there for a moment.
Long.
So yeah, so long COVID. So yeah, so the borough, well, South West London and the borough have put together a package relating to long COVID. Long COVID is an interesting one. Whether it's any different from any of the other post-viral syndromes that we've seen, only time will tell. But the features that we are seeing as part of long COVID are often ones that we see with other viral conditions. So glandular fever, I'm sure many of you will know, can leave people with long-lasting symptoms. So basically, there is a package of care involving both psychological and physical interventions that are available. So I'm not going to detail those, but if you have any, if anybody is experiencing long COVID, then if you go to your GP has been sent out all the data about the resources that are available in the borough for that. So yeah, that's covered off.
Brilliant. There were several questions around the impact on fertility, which you did cover, but there was a follow-up question to say, has an understanding of specific health conditions and impact and fertility been included in any of the trials to understand what the long-term impact might be?
Yeah, so as soon as anything gets into social media as a concern, you can pretty much guarantee that the authorities, the sort of health agencies, will particularly look at that, because we know that we're going to be, if it's in social media, we know that we're going to be asked questions about it. So yes, there's been a huge amount of work looking at fertility. You'll probably know at the start of it that we were very wary with vaccination in pregnant women, for example, because again the concerns were there about impact there. And as time has gone on, that's been it's been very reassuring that vaccination is helpful in that population. So yeah, so to date they're definitely looking at it closely, and to date there's been no evidence at all that fertility is adversely affected. Theoretically, of course, you wouldn't expect that, because the vaccination is in the same coronavirus group as the flu vaccine, and we haven't seen impact of fertility with that. So from first principles, you wouldn't be expecting to see it, and happily to date, we haven't seen it.
Thank you. The next question was just a clarification, really. You mentioned a lymph node reaction, yeah. And the question's asking you to clarify what you mean by a lymph node reaction.
Yeah, thanks. So whenever you get a sore throat, you get those glands under your neck. So those are your lymph nodes. So a lymph node reaction is an indication that your immune system is mounting a response. So just as when you get a sore throat, lymph nodes is a good sign that your body is reacting against it. Some people, when they're vaccinated, their immune system is mounting a response against the vaccine, they sometimes see lymph nodes. So it's not abnormal, is what I'm saying, if you get a few lymph nodes after vaccination.
Great. And then last question was around some further clarity on what you said about the side effects or the potential side effects of COVID, and that perhaps what you said didn't tie in with some of the other reports coming out from the UK or from the US about potential side effects. And a couple were mentioned, the yellow report in the UK, but also the VAERS report in the US, which have highlighted different and perhaps more significant side effects than you have outlined today.
So the side effects that were reported in VAERS were the same ones that they had reported during the clinical trial. So I don't think anything new came out from that other than the myocarditis, pericarditis, and that is a significant one. Because it can cause significant symptoms that may need attention. So in the same way that with the AstraZeneca, the thrombosis, we needed to get that information out there, because there's a group of people who, if they were to get those rare side effects, would need intervention. And similarly, with somebody's getting those cardiac side effects with Pfizer or Moderna, we do want to be identifying those patients. And as I said before, they will be presenting typically with the chest pain, the palpitations, and the shortness of breath. Those are the classical side effects of that. I'm not aware of other ones beyond that within the VAERS report system. So if anybody has particular details of those, and they want me to follow that up, I'm more than happy to do that for them. So if you can collect those questions, I'm more than happy to follow that up after this meeting for you.
Yeah, and I think you'll see some of those in the chat, Patrick. So there are some more questions in the chat which I will come to, but if anyone has a question that they want to ask now, if you pop your hand up on the Zoom meeting, we will get you unmuted and you can ask your question. So I'll just pause briefly to allow you to do that. If not, I'll return to the questions in the chat.
Yeah, I've just picked up the one that I think you were referring to, which covers more details. It covers more incidents of side effects. So the figures I was talking about from VARS were simply reporting on the adolescent population. So I think the report that you've that has been included there from Deep Blue Sea, and thank you for that, I think is the wider across all ages. So the subset of data that I was reporting to you related specifically to the adolescents.
Okay. So are there any questions that anyone wants to ask? So I can't see any, so I'll just go back to the chat. So there is a question here around when you think vaccination might be offered to under 16s.
I was in on a meeting earlier on today where we were being asked to prepare for 12 to 16-year-olds. So my guess is that it's going to be fairly imminent. JCVI, the Joint Committee on Vaccination, had indicated we might have expected some notification at the end of last week about this population, but it looks likely that it's probably going to be in a week or two. So, but I'd be surprised if it's beyond that. So I think that will be quite soon. There was a question earlier from somebody whose daughter is 15.5, or 15 and 5 months. I think it'll be long before the 16th birthday. So my expectation is that will be soon. I'm just running through some of the comments about people feeling pressured. Yeah, it's difficult, this, isn't it? So it's hard to tread that line, isn't it? You know, when you're in healthcare and you're seeing the impact on children and young people of the disruption to their lives because of COVID, and when you know that there is an intervention that is going to help to improve their quality of life to the extent that the vaccination program is likely to do so, it's hard to not give the impression that you're pushing hard. And I'm sorry that that does come across, because it's hard to hide that, because when you're working in clinical care and you're seeing those figures about 1 in 4 young women needing access to mental health input because of the impact of COVID. It's difficult to be completely dispassionate about that. So, I apologise if there is that feeling that people are being sort of bullied and harangued. I tried to draw attention to that earlier. It's really important not to do that. The job is to try to get the information out to you, and you will all make your own judgments. The youngsters will, when they have when they can give consent, they will all be making those judgments based on that information. But we haven't been in a good position in the last 18 months. We do need our children and young people to be able to move forward with their lives and careers without the residual effect of this. So I'm sorry, but it's the best intervention we've got to try and improve people's quality of life.
Great, Patrick. There are a couple of people who've got hands up now. So I'll just call your name out, or the name that you have entered when you enter the meeting, which might not actually be your name. And then you'll be unmuted, and then you can ask your question. So the first up is Ms. Jones. So the host will unmute you, and then you can ask.
Oh, hi. Oh, hi. Yeah, I'm very concerned because it does seem like a very low risk. I mean, I had COVID myself very badly. I'm obviously much older than my child, but it seems extremely low risk. And we have 1.5 years data of that illness. But for the children themselves, I don't feel like there is enough data about, we don't have actual figures about, for example, myocarditis or some of the other, blood clotting disorders and things that have happened. So I feel like I know what COVID is, but I don't really know what this vaccine is, especially as I didn't think it was this. I was told that it wasn't the same as the flu vaccine, that it was an mRNA, which actually is, synthesizes and sort of goes into it reacts in the body in a very, very different way. So that's what I'm very concerned about with the young people, because we shouldn't be vaccinating them to protect other people. And in terms of what's happened to them about their mental health, I totally and completely agree. But that's nothing to do. That's still, they still shouldn't suffer maybe by having to feel pressurized to have a vaccine that we don't have quite enough information about yet. Because I certainly know, I know one person who did have myocarditis, you see, and I think that is and it was very, very horrible. So that's my great concern. I completely pro-vaccine, by the way, like in every single shape or form. Like I actually asked our school to do HPV because I was sincerely worried that they delayed it for a year, and was worried about all those people that had then not, maybe could get HPV and be risk at cancer. And there was never this pressure about, say, MMR or meningitis, which really affects children from a very young age and severely, in terms of quality years. That has much greater effect than COVID on them in terms of the actual illness. So I feel that I just really don't feel they should feel pressurized to do this.
Yeah, thanks. I mean, I agree. People shouldn't feel pressurized. The data just needs to go out there and try and help. But we are in a position where you've seen the disruption to your children's lives, young people's lives. And the longer we go with that ongoing disruption, the more impact it's going to have. Yeah, just in terms of the vaccines, thanks for making that point about the vaccines. They are different. So the flu vaccine is a completely different vaccine. The flu vaccine is based on incorporating it's an adenovirus that that you add to chimpanzee cells, and then you manufacture it and go from there. The messenger RNA, just to be clear about the way it works, so the messenger RNA injected is actually only around for a few days. What the messenger RNA does is it tells the body to make the spike protein. So the spike protein is that little sticky out bit on the top of the virus. And what the body then does is it sees that spike protein, makes cells against that, and then stores those memory cells so that if something that's got that spike protein appears, then it'll mobilize those defensive cells. So in many ways, it's a much neater, a much cleaner type of vaccine production than the historical ones. So from a sort of almost from a purist point of view, the messenger RNA vaccines are a massive step forward in terms of what they offer. The actual messenger RNA is eliminated from the body within days, so it isn't hanging around in any way at all. All it's done in the meantime is taught the body's immune system to make the antibodies against the spike protein. So that genuine, from a scientific point of view, it's a much more reassuring picture. In terms of how much data, how for all of us, how much data individually would we want to have? I tried to just give you the number of adolescents in the States who they've looked at now, and it's 8.9 million that they've looked at. I don't know how many we individually need to feel confident. We're always going to have a sense of concern, because doing a vaccine is an active process, not doing a vaccine is a passive process. But there's a risk within action as well as a risk with action, isn't there, of course? And what you're trying to do with vaccination approach, trying to balance that. That's where we are, really.
So my thing about it is the fact that there's only, say, for example, figures today, there's 10% of the population have had a positive PCR test, so positive, but that's only 10%, and yet so do you see what I mean? Like that's 10%. That's actually relatively small if you think about how infectious it is. So that's my worry as well, is the fact that's 10%. But if we're saying sort of 75%, or however many that they want to get vaccinated in the under 16, 16 or 17 group, I am very, very concerned about that, especially because you're saying about Reading, they didn't ask for medical history. They just did they're just like people going up and they're drunk, and they're going up and getting a vaccine. I mean, I was really surprised. I mean, that really isn't, it's just really not the way forward in terms of encouraging people to take on for all sorts of reasons. That's wrong. And I don't know why they didn't ask medical history, but also just if you're under the influence, if you've been there's drugs there and everything, and they're getting a vaccine at a festival, it seems really inappropriate.
Yeah, I think there's all sorts of reasons why we would be anxious.
Done in a medical setting. Every other vaccine is done in a medical setting.
Yeah, I think
the festival, I think, is extremely wrong. I don't think should have been encouraged at all.
Yeah. So there's all sorts of things that happen at festivals that make us a little bit sort of twitchy, aren't there? My understanding though is that there was nothing about the pop-up clinic at the festival though that should have been any different from anywhere else. The same rules of consent, informed stuff should have applied there. I wasn't. I don't know the detail of it, but I do know that, and the same processes had to be followed in all of the sites. So
yeah.
Okay. I'm going to move on to the next question. I'm sorry. So the next person is Itsu Deep Blue Sea Holistic. If you want to wait till you're unmuted, then you can ask your question.
Hi. Hello.
Hello.
Hi. Thank you very much. I'm quite in line with what Ms. Jones previously also talking about. But first, before moving on to my question, just to add what Dr. Gibson told me about the spike protein that doesn't stay, but one of the Japanese independent research company carried out this research on the Pfizer. And what they found, and then a publication went all over the world now, said that the spike protein does stay over a few months. So they did the period of 14 days. And then what they found, so they traced the concentration of the spike proteins after the inoculation. So even though in the publicity, when they were rolled out, and what we are informed of was that the spike protein will only stay in the localized place. But what this research found out was that the spike protein actually flows all over the body, and then the quite high number of concentration was found in the ovary, and also liver and kidney. So those kind of very important detox organs. So that was one thing I wanted to ask, if it's spike protein. Yes, it's also, you mentioned that it's the very new and the promising, but at the same time, because of that reason, I worry more, because there is unknown quantity what this will do, because the previous mRNA vaccine trial failed after the SARS one. So that's my question for the spike protein, so mRNA protein. And also this mRNA, so when I looked at the recipients and in the spike protein, so this is AstraZeneca, so I have the one with the Pfizer-BioNTech, that first of all contains two different types of nanolipids. So this must be the spike protein component, but also on top of that, and that also has a PEG, polyethylene glycol. So this I wasn't informed of when the vaccine rolled out to the adolescent came out as a letter. I had to go and find the information myself. So when it comes to the vaccinating children over 12, so my daughter is on the spectrum, so she will be one of those being offered. But my concern is that would we have, or would we get the informed consent form that includes or that kind of disclose all the excipients of this vaccines, mRNA vaccines, so that we can make our informed consent and decision. I don't think I have had that one received.
Okay, are you okay to answer those two questions, Patrick?
Yeah, fine. So it's for the spike protein, first of all. So yes, you may well see spike protein circulation around the body. What matters, of course, is the spike protein causing any harm? That's really what you want to know. So the fact it's going around the bloodstream, it's immaterial as long as it's not doing any harm. Clearly, the data that we've got does not show that so far. So I know that there
data I've received from this was that they was causing the lesions. So the spike proteins are actually causing the lesions when they, so as they travel. So that sometimes is also causing the clotting on that local.
So if you want to share that data with me, I'm quite happy to look at that critically for you. Mm-hmm. I know that in the data that has been evaluated by the regulatory authority, they are not taking that view. So you may well find that there are some studies out there that have not met with peer review that validates them, but and that may be in that group. But I'm more than happy to have a look at that paper for you if you'd like me to. In terms of the nanoparticles, there has to be a process that makes something. You know, our every product we have in life is a mixture of different chemicals, and the nanoparticles is the fatty particles in which the messenger RNA is suspended, and it has to be suspended in that because it's very a brittle product. So if it isn't suspended in that, it can degrade and become useless. So that's part of why the storage specifications for the messenger RNA vaccines are so specific. So once, to start with, once out of the fridge, once out of the freezer, and had to only be kept for 5 days, they found that they can now keep it stable for up to 31 days. But that's the purpose of it. So if you're asking about all of the different, if on a consent form, would you consent to every single agent that's in it? You know, I'm not sure how practical that is. What you really want to know is what are the key parts to that. You referenced PEG, polyethylene glycol, and it's a constituent of many vaccines. And one of the questions that people are asked is, have they had reactions to vaccines before? It's also a product that's seen in many foodstuffs as well. So we're not talking about something that is completely alien here. This is something which is reasonably common in our community. And some people are sensitive to it, that's absolutely right, which is why we asked the question before vaccination as to whether people have had reactions to previous vaccines.
Great, thanks, Patrick. There are a couple more questions in the chat that I just wanted to come to. Some of them follow up on the questions that you've been asked already. So the first one is around, and this may well be for Asmat as well, is from Lucy, and that her daughter would like to see the data before she makes an informed decision about whether or not to have the vaccine. And the question is, what are the best sources of data for Lucy's daughter to look at?
So I would say for the young people, because that's the age group we're looking at here, really, isn't it? It's that US data, so that's that 8.9 million. So it's the if you want to look it up, it's the VAERS data there, vaccine adverse responses and reactions.
Brilliant. Then we had a conversation earlier around the Reading Festival and how appropriate it was to vaccinate children at the festival. But there is another question, which is around what percentage of 16 and 17-year-olds locally have been vaccinated, and what are we doing to make access to vaccination sites, wherever they may be, as easy as possible for young people?
So annoyingly, for the borough figures, we don't. There's a lag before we get to see that data on the 16 to 17-year-olds. So I can't give you a straight answer to that. I quoted the stuff I gave you during the presentation. Actually, is the most recent stuff we've had, but that was for the slightly older group, wasn't it? So we know that the uptake, as you've gone down the cohorts from 50 and 50 below, it has been a bit less with each cohort. But interestingly, when people in each cohort have been asked in advance where they're going to get the vaccine, the population has consistently reported lower figures than what we've actually seen in reality. So what we've noticed is, as people have seen their peers having the vaccination and having it safely, that's given people additional confidence, and it's been higher in all the cohorts than was expected. Yeah, did I miss, was there a second question there?
Well, there was a second question around vaccination sites for 16 and 17-year-olds, or indeed for all children. I don't know if you wanted to pick that up, Asmat.
I think in relation to vaccination sites, I know that CCG colleagues are working with PCNs or working through PCNs to provide those sites. So I think discussions are currently taking place in terms of where those sites will be shortly.
Yeah, and I think it's true to say our aim is to make sure that there is good coverage across our borough and that those sites are as accessible as possible to children and young people. Okay, and then last question that I've got in the chat, although I've seen another one appear, which is, how long after having COVID should a young person wait before being vaccinated?
Yeah, so if you've been pinged and tested and you're asymptomatic, 28 days from when you've had your positive test, and if you're symptomatic, it's 28 days from when your symptoms started. So you can get vaccination afterwards at that point. One other point that I just spotted in the chat, which was actually one of the questions brought up and I didn't answer it. And there's a distinction on the blood clots. So the blood clots is not an issue that seems to apply to the mRNA vaccines. It seems to be an issue with the AstraZeneca one, and that's not going to be available for this younger population. So the blood clots and the thrombosis that was reported is not relevant to this particular group of people. Just going back to where you can get vaccinated. So in terms of the PCN, the primary care network sites, what are probably known as the practice sites, really, Hampton Wick, Essex House and Acorn are vaccinating at the moment, and they're using booked appointment systems. The walk-in ones are going to be at Queen Mary's, at the Teddington Centre, Teddington Social Centre, and we do have one or two pharmacies as well, which I'm just trying to quickly pull up from my record there. So so our pharmacies, there's one of the pharmacies in Ham, Pharmacare, Teddington Pharmacy, Herbert and Herbert Pharmacy in Witton. Boots are also doing it in Kew, but not as a walk-in service. So those are the sites in Richmond that are currently vaccinated. There are phase 3 vaccination sites starting up at Greenwood as well, the Greenwood Centre, fairly soon.
In Hampton Hill. Great. Right, so last call for any questions before we close today's session. Anybody have any questions, please put your hand up so we can see you.
There's a nice one there in about efficacy, how long does immunity last? And the trials we've got to date show a very effective immunity out to 8 months. There's been really interesting stuff coming out showing that antibody levels can wane, and we are seeing that, but what really matters is whether those low antibodies are associated with developing severe disease afterwards. And I say the really good news is that even though we are now seeing people who've had the vaccination quite some time ago and antibody levels dropping, we're not seeing increase in hospitalizations in those populations if they are being unlucky enough to contract COVID now. So the good news is that even though antibody levels may drop, it looks like immunity is persisting beyond that, and people are obviously watching that very closely, and that's informing the JCVI in what they will decide to do about boosters, and we're still waiting to get absolute clarification on how the booster campaign will look.
Okay, thank you. There is one more question. It looks like it's from Tinuke Bell. I hope I've said that correctly. If you wait until the host unmutes you, then you can ask your question. Okay, please go ahead.
Hello, I'm sorry if you've already covered it, maybe I missed it, but you said that they're only going to be offered one dose of the vaccine. So we know that currently, adults are being told to get fully protected, you need 2. And you said that there's an 8 weeks that they have to wait for the second dose, I think, if they were going to have a second dose now. But so will they effectively be only partially protected? And I mean, if 18-year-old pluses are getting double vaccines, is there a stage at a later, a year later, if they got a second dose, would they then become fully? Or I just don't understand how it's going to work, because I guess from everything I've heard, they will not therefore be fully protected anyway with this single dose. So how does that all work?
Yeah, I think it's a really good question, Tanuke. It doesn't quite follow the logic that we've had to date. And you're absolutely right that the evidence to date has been that two vaccinations gives particularly more long-lasting protection. One gives you good protection, and full stop. But what the other part of the equation is, how long are you protected for? And that's the biggest benefit of having the second vaccination. The JCVI may well change their recommendation as time goes on. There's a suspicion that may happen, but for the moment, unless you're in a clinically extremely vulnerable group, the decision they've made so far is just to do the first one. But knowing how the JCVI have worked as the months have gone by, there's every chance that we will be asked to prepare for second vaccination for them. But I can't tell you that's going to happen, because JCVI haven't actually made that statement. But yeah, so a single vaccine does give less protection than 2 vaccines.
Thanks, Patrick. A question from Ms. Jones again. If you just wait till you're unmuted. Okay, please go ahead.
So, sorry, just with the last immunity, because if you've had COVID, like positive PCR test, blah blah blah, is it a similar type of length of time for natural immunity?
Yeah, on what we've seen so far, yeah.
So therefore, if you have had COVID, particularly maybe if you're younger, that there doesn't seem to be much point in having the vaccine if you've had it and it's been proven in that period of time. Because if it's only 8 months, you know what I mean? So therefore, because there's a lot of people that have had COVID, there's lots of, as you can see from the cases, they've had positives, particularly among the young, because of course they're being tested, and so it feels like that would be a kind of safer option for our children sometimes, if you've had it, to have your natural immunity and then wait till the next batch, which will be dealing presumably with the variants, like the flu vaccine, i.e. next year.
Yeah, I mean, the argument is that by having the vaccine, it gives a further stimulus to those memory cells. There are thought to be memory cells that are in the body that help you then to respond to subsequent illnesses. And the thought is you're just going to get an augmented immunological response if you have the vaccine as well as having had the illness. But obviously with that sort of that interval. But yeah, you're right. Logically, there is a decent protection that you're going to get from having had the illness itself. It's not, not vaccinating is not a zero sum calculation, because you at the end of the day, you either it's binary. You either get it or you don't, and you either get your complications or not. So it's just trying to look at ways of minimising the impact overall. And the understanding is that you're going to have more protection having vaccination, even if you've had previous COVID. That's what they're telling us anyway.
Thanks, Patrick. Right, so there is another question from Tanuke Bell, or unless it's the same hand from last time. We'll unmute you and then you can tell us. Go ahead.
Hi, it was effectively just the point that the lady just raised. Basically, both of my daughters, 114, 115, are on their final day of isolation. They both had, one lost, taste of smell, both had temperatures. And so yes, my 15-year-old isn't going to turn 16 till November, but I'm just trying to think ahead to November. She's literally had it in the past 10 days. It's only one dose, and it's just trying to go through that decision process. She is going to be someone that is going to make up her own decision. If I say, look, I just don't understand why we're doing this now, because, you know, it doesn't seem like it's the end solution, because it's one dose now, and it feels like, yes, in 6 months' time or a year, it'll be up to 2 or what. It just feels like an interim solution. She's had COVID, not just having a positive PCR test, but having had symptoms. I feel that she is there protected. I don't want to make the wrong decision, but I'm feeling a little bit torn here, that I'm not being given a clear, what should I do? Actually, I feel a little bit torn, and to be honest, from this talk, I'm actually almost thinking she has a decent amount of protection from having had COVID. That's what I'm feeling, until where maybe, you know, maybe it is 6 months down the line when we're either doing a full thing or there's another variant or whatever it is. I'm struggling here a bit.
Yeah, and it's not easy, Tanika, at all. You know, when you're a parent and you've got that responsibility for somebody, you know, it feels like the weight of responsibility. And I don't, you know, I think it applies to all vaccination. You know, my work, you know, I've had that sort of, you know, hard to make a decision conversation, yeah, for 30 years now, and I'm not sure it's any easier with any other vaccine, because you're trying to make a judgment about taking a positive step when the alternative is not taking a step and then sort of crossing your fingers. And it's not easy. It's not easy. It is true that, you know, there is significant protection from having had COVID, but the understanding we have is that there is additional protection from having had vaccine as well as COVID. That's ultimately what it comes down to. Yeah, and in terms of the single, as opposed to two, I think the JCVI are just looking at that risk-benefit analysis and giving themselves a little bit more time before they make the decision about whether to go with the second one. So, but we'll see. We'll only know that when we get to 8 weeks for that 16 to 17-year-old population, and they'll have either commented or not.
Okay, I think you just answered the question that was in the chat about the second dose, Patrick.
Okay, can I just go back as well to, there was a point made about with thrombosis having been seen with mRNA. Yes, it has been seen with mRNA. The question is, has it been seen over and above what you would expect to see in the general population anyway? And the VRS data does not show an increase in that over and above what you would expect in the normal population, whether they've been vaccinated or not. So what we're talking about is there an increase in thrombotic episodes with it? So that's just to clarify that point.
Okay, thank you very much. Well, I'm not seeing any more questions in the chat or any more hands are up, so I'm going to call the question and answer session to an end. Just to say thank you very much to Patrick and to Asmat for their presentations this evening and for fielding all of your questions. I hope you found this evening's Q&A to be useful and to provide you with the answers or the assurance that you were looking for. Thanks very much for your time and have a really good evening. So we're going to end the session now, and just to remind you that the recording and the answers and the information that we've presented this evening will be on our website. So thanks very much for your time. Have a great evening.